All right. So today I am talking about unicompartmental knee arthroplasty. Want to briefly start with morphology of arthritis of the knee. So up to 40% of patients have only unicompartmental disease, and this is most commonly seen in the medial compartment and even more specifically in the anterior medial compartment. The early symptomatic stages are slowly progressive, and intervention during this stage could delay or prevent total knee arthroplasty. So we're all familiar with the non-operative treatment options for knee arthritis, so I won't belabor them. The focus of this talk is really to talk about arthroplasty solutions for this disease, and specifically unicompartmental arthroplasty. I believe Dr. Crawford will be talking on realignment surgery in a few weeks, so I'll try to steer clear of that. So the rationale for uni is to replace diseased articular surfaces while retaining normal bony and ligamentous structures. It's to correct malalignment, restore physiologic joint motion, and to minimize morbidity. So standard workup consists of thorough history and exam like always, and then radiographic evaluation. Like you can see here, standing AP of bilateral knees, you can see bone-on-bone medial arthritis on the left side with a lateral joint space that is relatively preserved. On the lateral, it's actually kind of interesting. If you look closely at the concave medial plateau, you can see that most of the disease is actually focused in the anterior aspect of that plateau. I don't know if I can get my cursor up there. So if you follow the sclerotic border, it comes down and then comes back up, and then you have about the normal joint line posteriorly, which is another great hallmark of this disease, so you know you're doing the right surgery for your patient. And of course, if you're considering doing a uni as a treatment option, you should get a valgus stress view in which the knee is held in 20 degrees of flexion and the beam is canted 10 degrees cephalad to parallel the tibial plateau while a valgus stress is being applied. And you can see that the lateral joint space stays normal, which one would expect, but also, even more importantly, you can see that the medial compartment does open up and is able to be passively corrected. So while the notion of unicompartmental arthroplasty has been around for almost 60 years, the implant itself has come quite a long way. As conception in 1957, Dr. McKeever actually had a hemiarthroplasty solution with an all-metal tibia. However, now today's surgeon, you can see from our pictures here, has a choice of both mobile or fixed bearing devices with cemented femur and tibial components. So this is probably the most important part of my talk here is patient selection, as it's paramount for achieving success with the surgery. However, there are differing opinions on what is acceptable and what the actual criteria are. There are some groups who will take a more conservative approach and say about 5 to 7% of their patients are good candidates, while there are others who believe that at least 50% of the patients they're seeing are appropriate for this surgery. So what are the distinctions? So in 1989, Cozen and Scott proposed what are considered to be the classical indications. The top ones here I have separated. The top ones are pretty much universally accepted to be appropriate, consisting of pain isolated to the anterior medial compartment, preserved lateral compartment demonstrated on valgus stress, and intact ACL. So where things start to get a little murky is when you start talking about the patient. Cozen, again, who are the conservative folks, believe that the patient should be sedentary, older than 60, have a low degree of deformity with less than 10 degrees of varus with good range of motion and no flexion contracture, as well as a BMI less than 30. Keep in mind, these were first described in 1989. And then you come forward to about 2011 when Pandit did his study here entitled Unnecessary Contraindications for Mobile Bearing Unicompartmental Knee Replacement. And he demonstrated equal or better outcomes in 1,000 of his patients who did not meet the Cozen criteria in at least one of their metrics. And so they basically concluded that it's a good surgery for all ages, all activity levels, and all BMI. So quite different from what Cozen said. And furthermore, a year later, in 2012, Murray saw that survivorship was actually pretty good putting these in obese patients. If you look even at the bottom, BMI greater than 40 had a 98% survivorship. I don't know if this is because people aren't getting up and moving or what, but it's something to consider. And even more importantly, you can see that the higher BMIs actually have a greater improvement in their knee scores. So despite these aggressive indications, there still are, in fact, some absolute contraindications. You want to avoid inflammatory arthritis, non-localized knee pain, knee instability or the absence of an ACL, moderate or severe bi- or tri-compartmental arthritis, and osteoporosis. And now also what I think is incredibly interesting is that patellofemoral disease and lateral osteophytes are not contraindications for surgery, and people will say that it's safe to proceed in the presence of these. So why a uni and not a total? Everything I've told you so far have been inclusion criteria for total knee as well. So why would we choose a uni instead of a surgery that has a long proven track record and has great outcomes? So the advantages of a uni: it's less invasive, there's preservation of bone stock, and there's less blood loss. The uni is thought to have improved kinematics, meaning more natural femoral rollback or tibial rotation. And this was shown in 2005 by Patel in a cadaveric study, as well as in 2014 by Wilk in an in vivo study that compared kinematics, and they actually showed that the gait kinematics of someone after a uni actually approached closer to the age-matched control of anyone who hadn't undergone knee replacement. So thereby showing the kinematics are actually quite good. Similarly, in 2009, Dr. Lombardi demonstrated that patients who underwent uni had better range of motion and shorter inpatient stays, and they also had higher knee scores at 6 weeks post-op, indicating that they are recovering faster than those that undergo total. Also in 2012, Brown did a multi-center analysis that demonstrated the perioperative risk is lower in unis, as there is significant reduction in the risk of overall rate of complications from 11% in totals and 4.3%. Now, granted, the complications that they talk about can be as simple as ICU stays, which is debatable as to whether or not that's a complication. So, what are the disadvantages? Some would say that there's a reduced survivorship of a uni versus a total. It does have a demanding technique and certainly a steep learning curve, and it can have a difficult conversion to a total knee. So what causes reduced survivorship? So there's progressive contralateral compartment arthritis, there's polyethylene wear or failure. Failure can often be seen in these mobile bearing components with the poly being spit out. Aseptic loosening, tibial subsidence, failed malalignment components, and medial lateral mismatch. Basically, a lot of those are coming from intraoperative error. So with that in note, I want to address the learning curve. It is well known that the learning curve is steep with this, as it is a demanding procedure. And actually, Lindstrom et al. Performed a multi-center review over a period of 5 years, and they discovered that out of the 8 revisions that they did with unis, 7 of them occurred in the first year that their group was practicing with these. And then the next 4 years was only 1 revision. So their recommendation was that the surgeon perform at least 10 to 15 unis to maintain a reasonable proficiency. And this was validated later by Robertson, who said 23, and Baker at 14. But regardless, what you're seeing here is that there is a minimum number to stay proficient. And then again, talking about the conversion of uni to total, it is not the same thing as doing a primary total knee. The Australian registry and New Zealand registry proved this, as they show that the revision rates are higher than the revision rate of a primary total knee. And you should not consider the uni as a conservative procedure to delay total knee. So everything I've talked to you about, indications, contraindications, advantages, and disadvantages, I've actually presented mostly level 4 data because that's kind of what's out there right now. So you have to be careful about interpreting what you're reading. For instance, this is a well-done level 3 review of the Medicare database done by Dr. Bolognese, and it at first appears that there's a significant advantage of uni over total knee in mortality, infection, and thromboembolic events. And I actually pulled these tables not from his paper, but from another paper that was directly citing his just basically saying how good the uni is. But if you actually read Dr. Bola's paper and go on to his next table after that one, you'll see that they actually had to exclude 2,500 patients. And after they did this, then the differences weren't significant anymore. So actually taking a look at the paper and seeing what the data shows is important. And similarly, another example of the kind of data misinterpretation is papers that deem uni as superior because it has overall higher knee scores. However, this is because what they don't point out is that they're starting out at higher scores given their limited amount of disease isolated to the one compartment. So in their database analysis, Lion demonstrated that the overall magnitude or change in scores is actually identical between uni and total, which suggests that the uni and total actually do provide the same amount of relief and satisfaction. So in conclusion, medial uni is a viable alternative to a total in the right patient. What's agreed upon is that they should have isolated anterior medial compartment OA, they should have passively correctable varus, an intact ACL, and then the other indications are a little bit debatable. It does decrease perioperative complications. It's technically challenging, has a steep learning curve, great functional and kinematic results, and you need to have a critical eye when reviewing the literature. I'd like to thank Dr. Bolo, Dr. Wellman, and Dr. Lekevich, as well as the VA team, and open it up to discussions. Some points that I think are most interesting are obviously discussing those extended indications with BMI and age, as well as the lack of contraindication of patellofemoral disease and lateral osteophytes. And of course, I would love to know how to beat the learning curve, as I'm clearly still in it. And what is the optimal number of cases per year to remain proficient, and what predicted percentage of your cases is this? And also, if we have time, discuss revision of uni to total. Is it worse than a primary?
Sure, I'll be there. Yeah.
And I can talk about my experience if you want.
Please, let's go. None? Zero?
I can't be able to play the keeper prosthesis way years ago.
Probably that worked. Well, I thought that was a great talk, and those questions are good, but I was going to try to involve some of the other faculty, and we've got some other folks with experience. So I was going to ask sort of to lead into this, because a lot of folks are referred to you for sort of consideration of uni. What do you think about, and did you come across anything about full thickness cartilage lesions as a predictor for success?
On the medial side or versus left side?
Medial side. Not like as a contraindication, but more about like extent of disease.
So what I read was that you should have at least 50% cartilage loss or joint space narrowing within that medial compartment. I didn't see anything specifically about full thickness.
Yeah, I think there's no matter what it is, I think it's what you have to have at least. There's at least one reference that would suggest outcomes are more favorable or predictable if you do not. Like one of the few contraindications folks like Keith or Mike Byrd would have would be if there's not. I know this is obvious, but if it's just sort of thinning and not full thickness on medial or lateral side, on the medial side, femoral or tibial side, those are folks they get nervous about because it's not that true anterior medial arthritis pattern that they sort of like to have. Well, we have definitely another proficient unicompartmental surgeon here in Dr. Amendola. So Ned, what do you think the number is sort of for being able to do these sort of, I guess, well enough, per year? How many you feel like you got to do a year?
Well, I don't do a lot. I do meet the threshold. So I don't do hundreds. Where I came from, none of the joint surgeons did as many unis as I did. They did totals. This was the discussion. Was really why not a total in these patients? It's a progressive disease. It's a joint disease. Nonetheless, I totally agree with your presentation. I think these younger patients, so you get these post-athletic career patients between the ages of 35 and 50s that have unicompartmental arthritis. That it's usually bilateral disease. It's not kind of unilateral post-traumatic disease. So it's medial compartment osteoarthritis. I think those are good patients to do it on. The original data on unis came in older patients, less active patients. I think the curve has shifted to doing it in younger patients, so that may present a different, outcome measures, set of outcome measures that you presented as time goes on. But I think there's simpler unis to do than the Oxford uni. I think the Oxford, you do need a different level of expertise versus the standard uni, with a single metal back component on the tibia and on the femur. So I think there's some easier methods where the learning curve is probably not as difficult as the Oxford. I've seen a lot of problems with the Oxford uni. Maybe you have a lot more experience with that.
Well, I think I would only say experience because of selecting that implant for use. But I think I do think no matter what, it's a harder operation. I mean, I think a lot of it has to do with not being able to sublux the tibia. I mean, there's simple things, right? You can't really bring the tibia forward, right? Because the cruciates are intact. So even things as simple as cement removal and cleaning up in the back of the knees actually can be a little hard. I mean, and it's harder to sort of. I mean, I think it's a tougher. For me, it's a more. I am more stressed out about doing a uni than a total for me, like not even close. So. I guess I'd throw that out there. I mean, to speak to how you get out learning curve, where you got a little ways to go, but no. But I mean, I think it's important. I mean, it's good that you guys will be around folks that utilize it some. We're not like a high utilization uni center. If you like, as you guys know, there's places where the percentage of knee arthroplasty cases that are done approach 50% or above 50%. Not for this calendar year, but for me, last year was about 20%. And you said it really nicely. Cozen and Scott would leave you at 5 to 7%. So what do you think, Ned? What your guess would be? Are you at Cozen and Scott, or where in between, or what do you think your percentage would be?
I don't do totals.
No, I guess I'm just saying, like from a standpoint of, do you stick really strictly to the Cozen and Scott criteria for your unis, or do you have let your indications expand a little bit past that?
No, I would say it fits the Scott criteria, a little bit stricter. Patient selection, I think, is the key. I think he highlighted that in the presentation.
Any other questions from the audience?
I got a question about the learning curve.
Yeah.
So the learning curve in these articles were all from people who were learning in practice, right?
Yeah.
So what happens when you're trained as a trainee, like as a fellow or a senior resident? Can you beat the learning curve that way? Is there any data on that? Do you know?
I don't know if there's data on that, but I mean, the answer I don't know. I think probably there are centers that do enough volume where people, even in residency, honestly, probably would come out doing enough numbers to meet what was quoted there. There's another registry study that proposes for looking true at outcomes. One of the European registry studies says that if you're looking at outcomes, the volume is actually 30 per year to sort of protect yourself from an increased complication rate or failure rate. But whatever it is, it's 15, it's 14, it's 30. But there are some places that probably by volume and percentage of selection of Unicompartmental are going to probably have enough exposure for residents and for sure fellows to hit the number. I don't know that we're quite there. I mean,
So you're running the arthroplasty service,
yeah.
Adult reconstruction service. Do you think that in order to keep the volume up, all the units should be done by one person?
It's a great question. So I think maybe, to be honest. And so then were you the only person that would do them at all?
Unis? Yes. Yeah.
That's probably good, right? Because that meant the volume that probably made your service have a high volume of them for exposure to the trainees.
No, that's exactly right. Your selection criteria becomes a little bit better optimal because you're seeing kind of a spectrum of patients. You get the follow-up, and you're seeing the follow-up, and no, I would agree with that. And I think the other surgeons, the total joint surgeons, realize that as well.
And we did something like that with hip resurfacing and patellofemoral arthroplasty. So luckily, I was selected the person to do all of those. It was an incredibly painful procedure.
Well, like I said,
but Ned's here. We got patellofemoral, so don't forget that.
From my standpoint, it's better to have two people just in case. So
but I think what you're saying is very important, right? So it probably would be better to have one person, smaller number of people doing these operations. I think maybe have a little more higher technical challenge to them, and maybe have this question about being a little bit more difficult to do. All right, one question to finish this. So we've got to keep going because the expert to answer this just got here, but he knows his spot very well. So Robin, one is the last question, and so. Byrd gave the data about the concern about the revision of a uni to a total, being not sort of like, slam dunk that simple. In your hands, this is definitely a harder operation, notably worse than a primary TKA. Conversion of uni to total, we'll finish with that.
Yeah, I think it runs the gamut. You can have painful unis that maybe have a little bit of loosening or something, and it's really not that big a deal. It's harder than a primary, but it can be every bit as bad as some big primary or primary TK to revision TK. You have a lot of tibial subsidence or even femoral subsidence, and then you have to build up and treat it like a revision knee. It's a big deal.
I think that's a great point. All right, Byrd, that was a great job. Your discussion.